Hello, folks. Welcome to the MMOA podcast. My name is Dustin Jones, and we have a very special guest today, Steven Coen with SaRa Health. We are going to talk about all things RTM, or remote therapeutic monitoring. I don't know about y'all, but I'm seeing this more and more just thrown around about the potential, the possibilities, but just a lot of confusion. I think there's a lot of folks that can benefit from this conversation. So, Steven, thank you for taking some time out of your pretty crazy schedule. It's conference season, but thank you for taking time to clarify some things. But I want to start off with, why in the world are you so passionate about remote therapeutic monitoring? And I'm asking that question as a geriatric physical therapy, because we'll get that question a lot of, like, why are you so obsessed with geriatrics or older adults? It's commonly like kind of a bland topic, if you will. Why RTM? What's your story? How'd you get here?
So how did I find myself here? I've been in the software world for a while. So I started my first software company when I was in undergrad at Kansas State, which, believe it or not, that little nugget will come back,
Awesome.
come back around, and then spent years negotiating software contracts, implementing software, rolled out a BI tool called Tableau to 30,000 employees at Deloitte Consulting while I was there. I went to business school full time at UCLA and knew I wanted to start another company, and did not think healthcare at all. It's like, nope, this thing is way too complex. Like, I don't know why anyone does this. But I just proposed to my wife, who is a nurse on the floor, but more importantly, she's a type 1 diabetic. And that's around the time when Dexcom came out with their continuous glucose monitor that matched with the app. And I saw how it allowed her to manage her disease instead of being managed by it. And that was my light bulb moment of just like, oh, this is why people do healthcare. Like, I get it now. Like, I was 6 weeks into a full-time MBA program, which is a pretty darn ideal time to have a come to Jesus moment like that. And so I took every class I could outside of the business school, to the point where I had to get like called in for like, hey, stop. Like, you got to take your business school classes too. I was like public health, public policy, bioengineering, just like
Okay.
eating up everything I possibly could, and did an internship at Medtronic Diabetes. But ultimately, it was like, I haven't lived, that's not lived experience for me. What is lived experience is being a physical therapy patient. So I've torn my labrum, I've torn my ACL, my meniscus. At this point, I'm basically on a maintenance plan with my PT, Matt, because I still compete nationally as an Olympic weightlifter. So it's not like if I need PT in a year, it's when and how much.
Yeah, shout out Matt Sullivan, Onward, Kansas City.
Yes, shout out. Absolutely. And so that's how I got into it. So I bring a very different mindset to it. And why I'm so passionate about these remote therapeutic monitoring codes, especially one code today, will be two in 2026, which we can get into. But there is finally a way for PTs to get paid for the relationship they establish in the clinic and the trust in between. Right. And so to me, is like, there's finally a make money while you sleep code out there for the PTs, OTs, speech, CODAs, PTAs. Like, there's finally something out there, and it can really start to help solve some of this moral injury that we can get into in a little bit.
Yeah.
So that's why I'm really passionate about it. Is like, I would not be able to do what I do under the barbell today if it wasn't for the amazing PTs that have treated me. I wouldn't be able to pick up my son and throw him. There's things I wouldn't be able to do. And when I see more holistically what's happening to private practice, I realize that if not only it's not going to be just me, but if people like me don't step in and help, like, we're going to grow up in a world where I can't get treated by a private practice therapist. And that's scary as hell. Like, I don't want that. I don't want that for me. I don't want that for any of my family. I don't want that for any of my friends. And so by no means am I some sort of silver bullet, but gosh darn it, I'm going to try to help.
Yeah. So I think this is obviously very timely, as in so many different settings in physical therapy, not just outpatient, but in a lot of different settings, you know, especially when we're in network, when, Medicare is paying for our services, for example, is that our frequency and touch points has reduced dramatically. I think home health has probably been hit harder than anyone, to where what used to be going into someone's home 2-3 times a week, now the frequency may be one a week, one every 2 weeks, one every 3 weeks. And by the nature of that, it's automatically shifting our role to relational, to support, to education, to kind of supporting that individual through their journey. And so to be able to actually get paid for that, in the context of outpatient, that's huge. So for folks that are still like, but what is it? Like, so tangibly, like nuts and bolts, what is remote therapeutic monitoring? The first thing is so when you're saying codes, we're saying very specific to outpatient physical therapy.
So yes, Part B. Part B. Now, if you're in an AL, IL, absolutely, right. As long as
Okay.
it's Part B care.
Got it.
Part B, regardless of whether you're in, in a health system, treating in a private practice, mobile therapy, like just Part B, check, right? Like kind of like the first like
Yep.
flow chart question, and then this is where people get really confused, like because there's different vendors in particular will say RTM means this, RTM means this, RTM means this. And it's not dissimilar to any other CPT code, right? We're like, hey, neuro rehab, right? Is that the same thing for everybody all the time? Like, no, right? There's something different about probably for each and every patient of
Mhm.
exactly what you're doing within the confine of that CPT code, right? And so that I like to start with that as like RTM can mean something different to everyone, right? You can have some groups doing it very differently than you. That's fine, right? It's your culture. It's the way that you want to treat your patients. It's your brand that can help you define like what you're doing within the confines of that code. So their
Mhm.
codes today. There's four. There's going to be six as long as the proposed fee schedule gets finalized. Here, let's see, it's 10/27. So here in probably what 2-3 weeks. And the first code pays if you educate the patient and they stay on platform for 16 days. Pretty easy. We call that the connect code. Like it's a pretty light code to hit. And even within there, well, some of our groups do a patient handout. We really think that's a good idea. Like do a patient handout. Some do like a postcard. Some do like a script specifically, right? Like even within like that piece, there's already so much variation within a
Okay.
relatively simple code. So that's why I want to keep hammering on that is like there are codes. How you get to them is really up to you. All right. And then 98977, we call that the engage code. That pays if a patient engages on whatever platform you're using 16 times in a 30-day period. And so are they basically responding half the time or a little bit more? If so, check, then you can bill for that every 30 days while the patient is in active plan of care.
So
Starting in,
the
yeah,
sorry, I don't want to interrupt, but I just want to get some clarification. So engagement. So let's say I have a text that goes out that asks a therapeutic based question. And if they just respond to a text, for example, would that be considered an engagement?
check. So the exact language is day of data exchange, right? And
Mhm.
so the question goes out, the response comes back in, exchange,
Okay.
right? That is data being exchanged. And so, and we get some questions on this of like, well, does it need to be like a lot of data? Questions around that. It's like, no, like it needs to be clinically valuable data. And an example I'll give is one of our questions for any post-op patient. We're asking about shortness of breath, right? For any sort of post-op, complication risk. And question goes out to an actual patient. So this is a real story. Forget the exact framing, but are you feeling short of breath? Please reply yes or no. Patient replies yes. And it's like, whoa, that's not good. And so PT gets that, responds back through SaRa and says, short of breath, as in can't run a mile or can't get out of bed. And patient replies, can't get out of bed. PT just says, I'm calling you an ambulance. Calls the ambulance for the patient. They did have fluid building on their lung, but luckily was a relatively like as innocuous of a procedure as it can be, right? But that goes a lot worse in many, many situations without some sort of monitoring, right?
Yeah.
That goes a lot worse. And I think that's also where people are like, this is like a money grab and, all that is like, no, like take the situation, right? So that happened. Let's say that patient, let's assume they're Medicare. Maybe they're not. Let's assume
Mhm.
they're Medicare. And let's say that whole hospital stay was 30 grand, right? To get that fluid off. If that patient had a cardiac event, a minimum quarter of a million,
Oh,
right?
easy.
Easy, easy. So let's say 280, right? So that way the delta between 30 of what it was and 280 of what it would have been is 250,
Mhm.
$250,000, right? And if you're on average generating an extra, call it 100, even $200 per patient that you enroll in RTM, like that's it's over 100,000 patients. Or no, sorry, that's over 1,000 patients that can have no clinical benefit, no cost
Right.
savings at
Yeah.
all. Over 1,000 before Medicare even stops making money. Like they're in the green for 1,000 patients, and just from that one single thing. So like that's why these codes exist. Is absolutely, it is in a way a money grab by Medicare, is because they know that patients that have some sort of ability to communicate and an incentive for providers to utilize that and engage with the patients, they know that ultimately drives costs down for
Yeah.
their members. So like it is 100% a money grab by Medicare. That's fine. Like it's self-sustaining in
Right.
that way.
It's it, and for especially for outpatient clinicians that would say that, for example, like if you spend any time in home health, there's a big push and there's an incentive to prevent people from going back into the hospital. And that is one of the primary objectives when someone gets discharged and they're under the care of home PT on board, nursing, whoever, is out there. Like that is a huge, huge goal. And there's a lot of financial incentive to preventing that person from going back to the hospital, let alone the better outcomes that they're going to have if we can keep them in the home. And this is just an iteration of that, right? But in the outpatient setting, that we're actually investing in their health to prevent. It may be some of the best health prevention, the most effective that we have in the health. I shouldn't say the healthcare system, but in the current state of things, it's a good use of money.
It is very
So,
good use of money.
yes. So we have the connect code, then
Yep.
we have the engage code. You
Yep.
said there's 4. What's the third code?
So I like to bucket the last two into what we call the support codes. And so that
Okay.
is time spent supporting your patient in between visits. And so this could be data review of what the patient's responses are. That time counts. It could be calling a patient or the patient calling you. That time counts as well. So just really time spent supporting the patient in between visits can generally count towards that. And it's 20 minutes. 9980 is the first 20 minutes, 9981 is the second 20 minutes, and those are reset on a calendar month. So there is like
Okay.
it's different in that, for your connect and engage code, you're on a 30-day cadence. Kind of like if you enroll the patient on the 14th, it's 30 days from the 14th and go on. And the support codes or the time-based codes are on a calendar month basis. I don't know if they'll ever align those. There's been a lot of questions and comments to CMS to have those aligned. I think it's RTM receives a lot of, we'll call it guidance or like copying and pasting from RPM, remote physiological monitoring. And most times patients on RPM are on RPM for potentially life, right? You think of
Mhm.
a diabetic patient that has a continuous glucose monitor, like things probably not coming off.
Yeah.
And
Yeah.
so I think the difficulty, like the complexity of the 30 days versus the month kind of goes away when you just you have
Mhm.
that length of time where it's a little bit more onerous in the outpatient the rehab setting, just because like, well, if I enroll someone on the 22nd and like, but then like, am I going to get 10 minutes for all of those reasons, we tell
Mhm.
folks when they get started, whether it's with us or with somebody else, doesn't matter, focused on the connect and engage code to start, and then work in how the support codes like fit into your workflow, right? Like
Okay.
don't try to make the time-based codes a thing, or you're going to burn yourself out. And we see that
Yeah.
quite a bit.
Yeah, that was going through my head. So just for the real busy clinicians that, are there's I mean, there's so much to remember. You're thinking about time periods, you're thinking about, time-based codes, you're thinking of, when you have to do certain things, just that overload from the documentation standpoint. What does documentation look like for this to be able to record some of these interactions? And then like how practically speaking, how do you see people implement this in a manner that really lowers the cognitive demand of remembering and tracking 30 days and all that type of stuff?
So, by no means am I a compliance expert, although we've talked to quite a few.
Mhm.
As we've seen, and we went through and looked at a bunch of different payers' medical policies on this, and so there's a little bit of difference, but we have created our out of the box, if you will, documentation that we create whenever a billable threshold is hit, based on the most stringent payer policy we could find, which was
Mhm.
Anthem's.
Okay.
And so that's what we've done as far as like what's truly required from Medicare. I don't think I have a good answer on that. We
Mhm.
just like looked at all of it and just said, give us the toughest one, and then we just
Yeah.
use that for everybody else. But in that, we're like time period. So patient was enrolled from the time period was this day to this day. They engaged 21 times. SaRa has gone through the FDA's 513G process and has basically a letter saying that, yes, we do have software as a medical device functionality, which is quite important. So you need to be using a software as a medical device to collect this data from patients. And so we have all of that, and it's just copy paste into the EMR unless you have us doing the billing. So we've just launched in-house billing. So where you can actually sign the note within SaRa, and it's like done. Like we'll take it, we'll bill it for you, we'll fight
Mhm.
denials and do the whole thing.
Yeah.
And it's just like any other billing company. We just only do the RTM codes. That the platform should be tracking that for you, no matter
Yeah.
what you use. Like you shouldn't have to think about that. If you find yourself with spreadsheets, that's a problem.
Yeah.
And
It's 2025.
It's just 2025. That's actually one of the things that we do to learn of different product ideas, and we just ask our customers what they're using spreadsheets for with SaRa, and they're like, "Oh,
Oh my gosh.
you're doing that? Like, ah, okay. Yeah, we can fix that." Like our billing page, the first iteration, a guy named Ricky Overton out of Inspired Physiotherapy in the Nashville area, we didn't used to have a billing page. We just used to basically send an email, "Hey, this patient's billable. Here's the documentation," and that was pretty much it.
Mhm.
And Ricky was like, "Here is my spreadsheet that I use to track all of this," and we're like, "Cool, we'll build that." And then we just built it into the app. He's like, "Okay, I don't have to use my spreadsheet anymore." I'm like, "That's
Yeah.
exciting."
Yeah, there's a lot of PTs that are just learning what the cloud is, and I may be one of them. So yeah, that's legit. So you have your own platform. I know you have some integrations into some existing EMR, and everyone that's watching, listening, we're gonna dump all kinds of helpful links in the comments. But in some of those integrations, and you could pick just one if you want to, but like, is it in that native platform, or is it do you still have to go to your platform, or outside of that EMR? Like what do those integrations look like, and does it, like, how much does it add to what people are already doing?
So I'll answer that question. I think we need to get to the delivery model piece, which we can get to right afterwards. But we have a Google Chrome extension that lays over the top of like 20 to 25 different EMRs, maybe 30 at this point. And so whether you're on Prompt, WebPT, let's see, those are two off the top of my head. Raintree's web version, their
Clinician,
clinicians,
Empower, I think I saw.
Empower, yep, Empower, quite a few. Like if they have a booth at PPS, we probably
Yeah.
have it. I think it's a good way to put it. And if not, we can create it within about 8 to 12 weeks.
Okay.
So it's as long as it's web based, we can make it happen
Mhm.
within a couple months. And so what that allows us to do is actually like basically passively for you as a clinician or front desk or whoever, but actively for us, we're actively pulling the data of the patient's chart that you're in. And so if we see a patient that is not enrolled in SaRa that you're in their chart, we'll actually have a little tile pop up that you could just press plus, and it auto fills all the registration information from the EMR, and then you just tell us what you're treating them for, like what patient type is best, and
Mhm.
submit, and it goes. Like that's it. So you're talking like 2-3 clicks to
Dang.
enroll a patient. Or if that patient is enrolled, then when you're in their chart, we'll show you if you have an unread message from that patient. So you have another little like tile pop down, like two shows up, like, oh, I have two unread messages from Miss Smith. Like, let me hop into that. Also the same for billable codes. So if you're doing billing on your own and we see that you're in a patient's chart where there's billable codes, we'll have a dollar sign pop down, and you
Mm.
just click on that. It takes you straight to the billing page, so that way you can be able to bill for that patient. So
Yeah.
it's not like truly like in the EMR, but I am not going to say that by any means. But we like to think that maybe better
Yeah.
than if
Yeah.
you're in the EMR itself.
Okay. So have y'all had worked with anyone that's been audited?
We not to our knowledge. Yeah, not to our knowledge. There was, or I guess there was one group that did receive an audit that is in the ALIL space. Our codes were a part of that, but
Hmm.
but it wasn't, I guess, specific to our code. So I don't think we can say like, hey, we have successfully like, proven it through an audit. I don't think we can. I don't have. I would not feel right saying that today.
Yeah. But I imagine as an audit, when you're looking at potential Medicare fraud, for example, the likelihood of someone billing for a service they didn't provide, like the amount that they're paying out for some of these other codes as opposed to RTM, they're probably going to focus more on that than the RTM, for example.
We'll see. There are quite a few audits on the remote physiological monitoring
Hmm.
front, so RPM, which I think means likely there are going to be audits on the RTM side. But when you see the cases of RPM fraud that they're highlighting, I mean it's bad. It's like we billed for patients engaging on devices that were never given to the patient.
Solid.
Yeah. Like, so of course
Yeah.
it's not something we to ever be taken lightly, but
Yeah.
that's why we went through the 513G process. Like we only count if it's a day of data exchange, right? There has to be data from us, has to be data from the patient, like all of that. And so we've held a very conservative line in the sand. And so while it's not something I'm necessarily like looking forward to by
Hmm.
any stretch, I mean pretty darn proud of what we've done as a team to
Yeah.
prepare our clients for that inevitability. Like it's going to happen at some point to someone. So yeah, that's
And
that.
it's all trackable,
Yeah.
like the data, the in exchanges, it's objective versus like what I provided that I put in to that EMR, right? And what I billed for. And the water's a little more muddy in that as opposed to RTM. Like you got records, right, of all those
Yep.
interactions and touch points. So that is helpful. I'm just asking that as someone that's been through a Medicare audit and just having to prove every freaking thing that you did and how exhausting it can be. But like I just mentioned, it may not be as much of a concern with this compared to, some of the other codes that you have to justify
Yeah.
or
To your
document.
point, it's pretty darn objective, right? It's like,
Mhm.
hey, did this patient hit 98977? Like, give us all the documentation for the 98977. You'd have your consent form that we
Mhm.
supply to every single one of our customers that shows, informed consent for our team enrollment. That could be either written or verbal, but we're pushing everybody for written,
Mhm.
right? Because why wouldn't you? The documentation in the in your eval that we give to all of our practices, like, hey, here's a few different options for documentation to put in your eval template to be able to have that available, right? Like, here's why we enrolled this patient, and like getting into the actual, let's say it was for a 9977, right? Like, okay, and here is the entire exchange of what went out, what came back in between this and the patient. There were 18 days of data exchange, which exceeds the 16-day requirement. Here's
Mm.
what they all were, time stamped, right? All of that. Were we using a software as a medical device? Here's SaRa Health's letter from the FDA to say that, and like that.
Yeah. That's yeah, which, anyone listening to that should be like, "I don't wanna do that. I'll pay someone else to do that." It sounds like SaRa Health may be your fit. Do you have any, like, good stories or examples of folks that have seen, like, a lot of success from this? You got a bunch on your website for sure, but are there any that stick out that mainly work with a lot of older adults that it's really been a huge benefit to their practice?
The I'll highlight two because they have two different what we call delivery models. And to define that before I get into it, a delivery model, as we think about it, Sarah, is how you orchestrate who runs Sarah more or less at your
Okay.
practice. So we have groups that won't run what we call mission control, and so mission control is one either a person or persons that basically Sarah's their job. They are looking at the patient's responses, They're responding to patients when they can, when it's within, their ability to do so. And they're pre-charting for the treating clinicians whenever there's, good information. We have an AI generated summary that they just pop
Mhm.
right in. So that way, really the subjective portion of the SOAP note's done by the time the
Okay.
patient comes in. Like that's the idea. And they're the ones engaging. Those groups will bill more of the time-based codes because they have time. I guess that's
Mhm.
part of it. And so patient replies that they're having trouble with their home program. Like, oh, like, hey, Dustin, would it be a good time to give you a call? Like, PM today. Great, I'll do that. Right. Boom. And you can just see how that process goes. And so if you're a group that has at least, I'd say, like 6 FTEs for clinicians, probably should start thinking about mission control and how some simple math. If you're not going after any of the time-based codes, you could probably do 1 hour a day per 100 patients on the platform. Like that's about
Okay.
what we're seeing on that. Maybe even north of that as you get used to it, but then you maybe want to have to go after some of the time codes. And anyway,
Yeah.
so that's what we're seeing. And so there is a large group that's actually, no, I'll use a different example for mission control that I just love it. A group called APTS out of Fayetteville, North Carolina. They were about to lose one of their top therapists, their rising stars. Her husband's in the services, armed
Mhm.
services, or armed forces, and was getting deployed basically out to San Diego. And so the clinic owner, Nisha, told the PT Bree, "Hey, Bree, figure out this RTM thing because we want to keep you around. We just got to figure out how to do it."
Wow.
We demoed with them. We've been working with them for, gosh, almost 2 years now, I think. And yeah, Bree is, I think between like 40 and 60% of her time is spent basically running mission control for a 10 clinician practice, and they are generating quite a bit extra net income, like net income. So after getting reimbursed, paying Bree, paying us, and then net income, quite a bit of extra net income per month. I don't think I'm allowed to share, so I won't. But
Do you know how many clinicians are gonna go to their their manager now? Like, "Hey, I bought this new van. I'm wanting to travel across the country. I will figure this RTM stuff out for you."
and we will
We're getting
help
a
you.
lot of
Yeah,
remote PTs from that
and we
from
will
that.
help you. And we haven't really talked about the new codes coming out in 2026. But if this physician fee schedule gets finalized as is, which based on the commentary of CMS within the fee schedule itself, I expect it to, instead of the goal being getting to the 16 days of data exchange, there's going to
Mhm.
be a new code called 98XX5 that pays for 2. So
Mm.
now ran all the numbers and said, okay, of the groups currently with us, how many of these new XX5s would they have billed in the same time period? And basically, it's going to between double and triple our customers' revenue as a result
And
as soon as 2026 hits, which we're really,
and
really excited about.
you said on average, was it like an additional 1 to 200 per
Right
patient
now
or
it's like
per care?
50 to 60, and as we look at 2026, 100 to 200, and that's assuming zero time-based codes. That's just yeah,
Yeah.
yeah.
And clinicians, I think if your company implements RTM, and I think this is a big issue in our professions. We don't necessarily know what we're worth or what we're generating. So that should be a conversation to have with the clinic owner or whoever. Like, just be aware of what you are generating for that business, because you should be paid fairly, even in
There
the day of reimbursement cuts and all that fun stuff. But
Well, it doesn't. So
just to be
here's what we
aware.
find that's really funny on that note is that we have found, with some rare exceptions, if a practice is not already some sort of like RVU or productivity based bonuses before starting with SaRa, and they try to do that as a part of it, it actually ends up more or less ruining the entire thing. So clinicians will think it's just a cash grab as a result, and there's no clinical value. They won't use it. It just ends up going all bad.
Mm,
And so that's a yes. I encourage clinicians to have that conversation, absolutely. But if you're an owner out there being like, well, I don't really do that today, like everyone's on salary, should I do an RTM bonus? No, like at least not
mm,
at that level. Now, what we have seen be successful is like a middle ground
yeah.
is, hey, I'm owner and I'm going to establish like CEU pool or like some other
Okay.
continuing education pool or like some other culture pool of cash that I'm funneling some of the margin back from the RTM codes into,
Nice.
right? And so we have seen that be successful. But yeah, if you're not doing anything productivity based today, don't have RTM be your first, or I can guarantee like which we probably should not even work together. Like, hey, this is going to be an absolute dumpster fire.
Yeah.
We should just not do this.
Yeah, yeah.
Has been our experience on that front. But yeah, so APTS is a great mission control. As I
Mhm.
think of the like clinician driven, which is you're treating clinicians or owning that messaging in the relationship with their patients. There's quite a few that I can come up with. I mean, you got the story of the patient I said earlier. That
Mhm.
was a group called Ortho ND. They're a PT group within an orthopedic practice and see a lot of total knee, total hip in that more geriatric population. And it's like, it's nice. Like, I don't have to worry about like, hey, is Miss Jones okay? Right.
Right.
Like that nagging feeling of that, like that moral injury is to a great degree healed.
Yep.
And so like that piece of it is really nice. And then, yeah, just making a more efficient start to the visit, right? Cause like the
Mhm.
subjective portion of the note is done. Like it should be done. It's not, hey, Dustin, how's it been going since we last saw each other? It's, hey, Dustin, I see that your pain is going down, that you did your home program, but you're still having trouble with stairs. Like I would have expected that to be a little bit better at this point. Can you like, and we're going to go over here and that's where we're going to start. Like, boom.
That alone. And that's just is it AI interaction back and forth and then taking that information into the EMR?
We do not automatically respond to patients outside of a very, very select, like there's a
Okay.
very select, because then that would have to get us into like the class 2 FDA and like that
Mhm.
it is a whole thing.
Yeah. So clinicians are going back and forth, responding, and then it's just taking that info automatically into the EMR for the subject.
We do not take it automatically into the EMR. You'll just need to copy and paste from our either AI generated summary or from
Okay.
the text chain. We don't, yeah, writing documentation.
Yep. Yep. Yeah,
We'll make it really easy to copy paste, but like I don't want to start writing a note.
I love it. That's really helpful. So, one last question. So part B, we're kind of basing off of Anthem, which is the most stringent. Is this applicable to folks that are non-Medicare?
Oh yeah.
So when you say Anthem, or is it Anthem like a Medicare Advantage plan, or like it's not age dependent? This
It
is
is not
anyone.
age dependent, no.
Okay.
But in the geriatric population, the likelihood that there's going to be coverage is absurdly high.
Yeah.
So what we have seen, Medicare Part B, obviously, like covers extremely well. Then your replacement plans or your Medicare Advantage plans cover extremely reliably. So Part C plans are forced to follow the B fee schedule. They do have certain things they can opt out of. But even, and I think a perfect example of this is Cigna. Cigna in their commercial plans had in their medical policy a negative coverage decision. Like we don't cover this, but their HealthSpring plan does, which
Mm.
is their Medicare Advantage plan. So, or one of their Medicare Advantage plans. So the if you have a high percentage of Medicare Part B and replacement plans or Medicare Advantage plans, the likelihood that your coverage is going to be extremely high is extremely high. Like it,
Yeah.
and it doesn't matter if you have per diem, whether you have CPT code limits or some sort of per diem rate. I had this conversation with billers almost, it's closer to once a month now. But like, hey, we only get $65 a day from United. I'm like, don't worry, bill the codes. You're gonna get a
Hmm.
check for probably like probably 140.
Mm.
And like, there's no way. Like, okay, let's come back in 45 days. Let's just
Yeah.
see. And sure enough, they're like, hey, we got a check for 140. It's like, let me guess, $65 for the visit, and then 19 for 99.75 and 56 for 99.77. They're like, it's exactly what we got.
That's wild.
They're not perfect. They're not perfect, right? And so of course there's still all sorts of fun, which is why we took RTM billing in house
Yeah.
to help fight those things. But yeah, even if you have like day rates, you're like, well, what if I bill this in the same day as a visit? Typically, things go well, not all the time, but typically things go well. Then you got your Humana, United, Aetna Humana commercial plans are all pretty reliably paying. Got, let's see, Cigna commercial does not. Your Blues plans are going to be Blues plan dependent. Even within there, there's some variation. So we're seeing like Blue Cross Blue Shield of Illinois, their own, call it like their own offering, if you will, does not pay for it today, but a lot of the self-insured employers plans that they administrate do pay. So like you're just seeing like this continual like diffusion into the
Okay.
market. Blue Cross Blue Shield of Kansas just started covering in February. I've heard that Care First out in Maryland area started covering in like June or July. So like it's going to happen
Mhm.
to when it's going to be ubiquitous, whether it's this, next year or the year after, I'm not sure. We're starting to, we're not there yet, but we've partnered with a PT group and their IRB to start pumping out research to be able to support RTM's clinical value. And so we're
Mhm.
going to lead from the front and start just pumping out research and white papers to show like, what we already know, which is the stronger the relationship, the better the outcome. And there's really good research to support that.
Yeah.
But if a relationship is a product of time and energy and clinicians don't have a surplus of either, then we have to figure out a way to get some of that back. And I think RTM is a great way to be able to do that.
Yeah. It definitely sounds like it, man. I mean, just the amount that we pour into people, and especially in the outpatient setting when there's a lot of things where we continue to pour, but may not be getting much, out of that from that building standpoint. So
We could create a
really,
really nice flywheel, right? Like, okay, like,
yeah,
hey, patient engages. Okay, good. Like clinician gets that data, is able to make like a more informed clinical decision. Like, oh, I
hmm
like that. Well, then, okay, patient continues to engage more because now they know their data is valuable to the clinician, right? Like they're making their doctor happy, and then boom, so they engage enough to be billable, but clinician didn't have to technically spend like any additional time, and now there's more margin here. Like, oh, well, we can dedicate more time to this, right?
yeah,
Like, and you could just see that flywheel go.
yeah, 100%. I love it. Well, for folks that are like, man, this RTM stuff, I'm really interested. I want to learn more. What's the best place to, yeah, just hear more about SaRa Health and your offerings?
Yeah, definitely. You can check out our website at sarahealth.com, SARA health.com. Just email me directly. So Steven, Steven, at sarahealth.com is my email. Yeah, just shoot me a note directly. I'm always happy to find time and chat about this. I'm really passionate about helping. I mean, helping get ahead of a potential negative world that could exist if we don't provide some relief and provide some better financial outcomes for private practices that I know and love.
Yeah. Yeah, I think this is encouraging and good news in a climate where what we usually hear is how we're gonna get paid less and reimbursed less. So I appreciate all your work, the innovation, the drive. You're solving a really, really important problem for a lot of us. So I appreciate it, Steven.
Oh, thank you, Dustin.